Hey everyone, and welcome to This Explainer. Today, we're looking at one of the absolute highest stakes scenarios in modern medicine. We are talking about a critical maternal health breakthrough that is, quite literally, the difference between life and death. For decades, a truly terrifying pregnancy complication has forced doctors into these extreme, highly hazardous surgical corners. But as we'll see, a recent wave of medical innovation is entirely rewriting the playbook. To understand why this breakthrough was so desperately needed, we actually have to go back and recount a really terrifying near miss from 2010. Dr. Edwin Chandraharan, a consultant obstetrician, was urgently summoned to an operating theater. His colleagues were in there desperately struggling to control an ongoing, massive postpartum hemorrhage. The patient had lost a staggering 6.5 liters of blood. I mean, just think about that for a second. That's more blood than an average adult even holds in their entire body. Dr. Chandraharan was forced to perform an emergency hysterectomy just to save her life, and she ended up facing a grueling, prolonged recovery in the ICU. But that harrowing experience, it forced him to think outside the box, and it ultimately led him to invent a brand new surgical method to save future patients. Okay, let's dive into this and define exactly what the antagonist of our story is. Placenta accreta spectrum, or PAS, is an incredibly dangerous condition where the placenta abnormally invades the uterine wall, that's the myometrium, and sometimes it even bursts right through it into adjacent organs. And because of the massive abnormal blood vessels that form during this invasion, PAS carries a staggering global maternal mortality rate of 7 to 10%. Let's start by looking at the history in Section 1, the flawed standard. Now, what's really interesting about this slide is how vividly it illustrates the physical reality of PAS. As you can see, the placenta isn't just resting safely inside the uterus. It is actively invading surrounding tissues, like the urinary bladder right there. If a surgeon attempts to manually separate or pull that placenta away, it instantly triggers torrential, life-threatening bleeding and catastrophic surgical injury to those surrounding organs. It's a surgeon's worst nightmare. Because separating the placenta used to basically be a death sentence. The historical weapon of choice against PAS was the peripartum hysterectomy, meaning removing the entire uterus with the placenta still trapped inside. But here's the thing. This approach was fundamentally flawed. It resulted in massive collateral damage. On average, patients suffered a blood loss of about 3.7 liters. The maternal mortality rate sat at 5.7 per 100 emergency hysterectomies. And in low-resource settings, that grim statistic spiked to 11.9 per 100. Let that sink in. Plus, it carried an incredibly high risk of accidental damage to the urinary tract and the bowel. Realizing that hysterectomies were causing all this massive blood loss, some doctors decided to try a radically different, conservative approach. It was called intentional retention of the placenta, or IRP. The idea was surprisingly simple. Just cut the umbilical cord, leave the whole placenta inside the patient, stitch her up, and let the body naturally absorb it over time. But as you might guess, while avoiding immediate bleeding, IRV was essentially a ticking time bomb. The statistics were pretty grim. It came with highly increased risks of severe sepsis and coagulopathy, which is where the blood actually loses its ability to clot. In fact, nearly 42% of patients faced a delayed hysterectomy anyway. And overall, 57% eventually required the complete removal of the uterus later on, often demanding secondary emergency surgeries. So a completely new, innovative solution was desperately needed here. Which brings us to Section 2, the Triple P breakthrough. So this brings us back to Dr. Chandraharan and the life-saving procedure he invented in 2010 to completely change the standard of care. He called it the Triple P procedure, and it breaks down into these 3 brilliant mechanics, the 3 Ps. Step 1, perioperative placental localization. That's finding exactly where the invasion ends so the surgeon can cut safely above it. Step 2, pelvic devascularization, temporarily cutting off the blood supply. And step 3, placental non-separation, leaving the placenta attached but cutting out the invaded uterine wall. Let's look a little closer at how this actually works in practice. The very first step requires ultrasound to precisely locate the upper border of the invading placenta. Then, using this very specific St. George's boat incision on the rectus sheath, they can access the uninvaded, totally healthy part of the uterus. They avoid the vascular danger zone entirely, which lets them deliver the baby safely.
So, the crucial point is what happens immediately after the baby is delivered. Before any more cutting happens, a highly specialized interventional radiology team inflates these tiny, occlusive balloons that have been pre-positioned deep inside the mother's internal iliac arteries. This high-tech maneuver drastically drops the blood pressure and flow to the uterus. It practically turns off the faucet before the major surgery even begins.
And now we reach the absolute genius of the final step. Instead of trying to peel the placenta off the uterine wall, the surgeon just cuts out the invaded section of the uterine wall en masse, with the placenta firmly attached to it. Furthermore, if the placenta has invaded the bladder, they deliberately leave about 2 to 3 centimeters of placental tissue attached to the bladder wall. This brilliant compromise prevents catastrophic surgical injury to the bladder, and studies actually show that this tiny remnant tissue safely resorbs on its own within just a few weeks. After that, the healthy uterine wall is stitched right back together. Now let's talk about global reality in Section 3, Adapting for the World.
The original Triple P procedure is incredible, right? But it immediately hit a roadblock when it came to global healthcare. Think about it. Step 2 requires a specialized interventional radiology wing to place balloon catheters into deep arteries, 24 hours a day. Honestly, not every hospital in the world has that kind of funding or infrastructure. So the medical community had to ask themselves, how do you perform this life-saving surgery without the high-tech balloons? And this brilliantly illustrates how frontline clinicians around the world answered that call. Take a look at this flowchart. Notice how the first and third steps remain completely identical. The procedure only branches off at the second step, the pelvic devascularization, where they swap out high-tech radiology for manual surgical techniques. To achieve that vital drop in blood pressure without balloons, surgeons in lower resource settings develop some incredible MacGyver-style innovations. They use highly cost-effective techniques like physically tying off or ligating the internal iliac or uterine arteries. Others use temporary surgical clamps. Some even apply a literal tourniquet, tying it tight around the lower segment of the uterus to restrict the blood flow before they begin cutting out the invaded tissue. Let's look at the hard data in Section 4, comparing the outcomes. We know the theory is brilliant, but let's move to and see how this builds an undeniable case against the terrifying historical standard. Just look at this massive, life-saving drop in blood loss. While the traditional hysterectomy resulted in an average loss of 3.7 liters, the original Triple P drops that down to 2.31 liters. And astonishingly, the modified Triple P brings the average estimated blood loss down even further to just 1.4 liters. But of course, blood loss isn't the whole story, as this data table reveals. We have 75 patients analyzed for the original Triple P and a much larger sample size of 654 patients for the modified version. And while both are fantastic, the original Triple P is vastly superior when it comes to preventing surgical complications. It boasts a remarkably low bladder injury rate of just 1.3% and a 0% peripartum hysterectomy rate. So you can see there is a clear trade-off here. The original Triple P, relying on that precise balloon radiology, almost completely eliminates the risk of losing the uterus or injuring the bladder. The modified version, however, offers much wider global access because it doesn't need a $1 million radiology suite. But because those manual methods, like tying a tourniquet around the lower uterus, just aren't as precise and can sometimes cut into the bladder if the placenta has invaded deeply, the modified version carries a 15.9% bladder injury rate and a 6.1% chance that a hysterectomy will still be needed. Yet, even with those trade-offs, the conclusion from our source material is a truly victorious one. The data confirms that both procedures are phenomenally successful at their main goal, avoiding the devastating historical standard. They successfully save the mother's uterus, greatly reduce surgical morbidity, and literally pull patients back from the brink of fatal hemorrhage. Which leaves us with one final thought. The data is in. We have undeniable proof that a conservative, uterus-sparing approach works and saves lives. Yet many hospitals around the world still default to the highly dangerous emergency hysterectomy. So what will it take to evolve these historical obstetric practices and finally make the Triple P procedure and its modifications the true global standard of care for maternal health? Thank you so much for joining me on this explainer. I hope this look into medical innovation leaves you as fascinated and as hopeful as I am.